morning. Thanks that I'm be here and that I can show our new techniques for viewing the ureter and how you can find really fastly the fistula, the ureteric fistula. Come on. The main problem in our hospital, we are a really big hospital. We have a lot of faculties in it, and we had a lot of complication problems from the other departments, from the surgery and from the gynae. And we have a problem that we get a lot of fistulas. And how to find it? It's in typically urology way, sometimes really problematic because we haven't no much time. That's why we create a new technique to find it also in ultrasound. The problem is, at the 7th day, you get a fistula after laparoscopic treatment. For example, in gynae, mostly is it then the hysterectomy, and it's developed the fistula at the 7th day. And how you can find it really carefully, we know the urology way. The urology way is it to make an X-ray, to show it with X-ray retrograde, or to make a CT scan to find the fistula. During the last years, we find now more than over 60 fistulas and replace it also very well. First, I want to show you the technique of ureteric ultrasound. It is really simple to show ureteric ultrasound. You see it well, that you can take the probe inside of the vagina and then you go left and right side and you see the ureter. This is the same like what you do in a gynae, but the difference you will see now then. The difference is that you go 2 centimeters back to the bladder neck, and then you can see really exact where is the bladder, where is the ureter, and you can find then these things. You have the chance to find pre-vesical stones in 99%, really exact in 1 minute. You can find ureteric tumors, you can find also some sutures inside of the ureter, only with ultrasound, and you can find the then materials that is. Come on. This is a normal view of a ureter, and to see it, it is really simple. You go on one side with your probe, and then you see the ureter. You go then on the other side, and you move the probe, and you see my hand. My hand is important. This is like the probe and the viewing, and the ureter goes straight away behind the bladder. So you need to curve your probe on one side and the other on the other side. And we called it the Kung Fu technique. It is really important. Kung Fu technique means that you curved the probe on the right side with your hand on right and left on your left side. It is like you do it at Kung Fu, left and right side, and so you have the chance to see the ureter really exact. One side, right side, on the right movement, and on the other side, clockwise in the other side, 45 degrees. Now it is really important that we have male and female. In a male case, you have a chance to see the ureter from vaginal 1.5 centimeters over the arteria uterine. So you have a chance to see the distal ureter really exact at the first 5 centimeters. If you have a male or a female, a better view, we are urologists, it's from transrectal. So you can see the total ureter till to the vessel border. This is really important. And we have now the chance, without any MRI or CT scan or X-ray, to see the ureter really exact. This is what I want to show you. You see here a typically urology case. The gynae make a corpus suspension, TVT, TVTO, all was crazy, postoperative hydronephrosis. And what you see here in the deepness, from abdominal view, it's a dilated ureter. But from vaginally and transrectal, you see the dilated ureter and you see the white point. This is the part of the 80 bond suture. They captured the ureter straight direct. You can see it with ultrasound. In MRI, you have no chance to see it. In ultrasound, you see it very well. White spot in the midline, you see the dilated ureter, and you see the white spot. There is 80 bond suture. They are sutured through the ureter. And this is what is really important to find with the technique of Kung Fu technique to see the ureter. Also stones. 99% of all prevesical stones till to the vessel border. You can see in ultrasound with this technique very well. You see it here. It's a 5 millimeter stone. It's 1.5 centimeter from the ostium. And if you know this technique, the Kung Fu technique, to move on the right side, one side with a probe, on the left side moving, then you can find it very well. And you can see it. You see it here. This is a stone. It is a jumping stone. You see it now, it's jumping inside of the bladder. And this is what you can see in ultrasound really exact with this technique. What we develop now from the typically Kung Fu technique to see the ureter really exact is that we want to see now where is a fistula. If you can find the ureter really exact, now you want to see a fistula. You go with the probe also inside, you see your ureter now, and what you've done is that in a fistula you can make a movement, and this is then a pumping probe technique. That means you take your probe inside of the rectum or of the vagina and you can pump, go forward and go backward. And if you do it, you will see then a movement inside of the fistula, and then you can find the fistula only with ultrasound. A really simple sample. This is a fistula on the roof of the bladder. That was a laparoscopic second view after ovarian cancer. The gynae make energy on top and you create a fistula. You see here the fistula, also in elastography, and now you see the video. The bladder is full, the urinoma is in the Douglas pouch, and if I pump, you see the fluid and the fistula is opening. This is important to pump. Go forward, go backward, and you see then the fistula. You doesn't need any more X-ray and MRI. You can see it without any other diagnostic. Also here, this is a bladder cervix vaginal fistula. You see only a small spot, and the small spot is movement. Only if you go forward and backward. You can find also a channel of 1 millimeter of a fistula. You hasn't any chance to find it also with X-ray really exact, because sometimes it is closed, but with pumping you can open it and you go forward and backward and you will see it. Here it's also. This is what we are interested in, the ureteric vaginal or ureteric rectal fistula. Go forward and backward. You see the ureter and you see it then. If you're moving, then it comes the fluid also to your probe and you see it where is the mistake. Also nice case. That was an end-to-end anastomosis from a gynae with a PDS suture. And with forward and backward. You see there's also a stent inside, but you see there's not correct suturing. There's a fistula between the ureter and the vagina, because before he preferred do a laparoscopic hysterectomy, cut the ureter, suture it, but in ultrasound you can find with these techniques the fistula, and you can find also the material, and you see which kind of suture there is. This is really important also for the troubleshooting what you done next time. This is a case what we see now in ultrasound. You see it here. This is not correct sutured. You see here in the deepness the suture material, and later we put then a stent on top to cover it really exact, and it is then simple to see. Go forward and backward, and then you will find the fistula, and you can find also the materials there around, and also the reason for it. In case of a fistula, if we see it, then we put also a stent inside, but not a typically stent. We do then, in these cases, a fully covered stent inside. And the fully covered stent inside make the fistula in the same moment where we put it inside it, then dry. It is really simple to do it. We put the stent inside, fully covered. It's like a hard stent, litinol covered around, and then in the same moment the leakage is closed, and the fistula will be dry, because after 6 to 8 weeks all the wound healing is gone, and you doesn't need any more treatment for it. Because if you do it firstly in the first 4 to 6 weeks inside that stent, then it's no problem. Really simple. You see then here's the stent. It is looking inside of the bladder, all it's covered, and the fistula will be closed. This is the ultrasound view and the Kung Fu technique. You see it totally covered, and the blue sign is the fistula. The fistula is in this case 3 millimeter open, but if you put it inside, no leakage, the patient is dry, you can wait and then relax, and after 6 to 8 weeks you put it out, and it's the problem is gone. Also, the next case, what you see here, the stent is inside it, and the small fistula on that sign, you see it here. You see it also in elastography. You can see it very well. The fistula you can find with ultrasound better than with X-ray and MRI or CT, and it's easy, it is cheap, and it is fastly. Every of our youngster can use also this technique. That's why we are a big hospital with a lot of problems. We have also some radiologists, they don't like us, because in the night to make an X-ray, you know it itself. If you want to have some pictures for this one, they use their own diagnostic, fastly and easy. You can find stones, you can find fistulas, you can find the problem. The important thing is that the detection rate of distal problems of ureter are really high. For stones is at 99%. For fistula you will get it in 90%, and it is recommended from us that you use only the B picture, the B mode, because it is interested if you use also elastography, but nobody has it all, because in the B picture you see it with the technique, pumping probe, forward, backward, really exact, and then it is simple to find. And next is, in local anesthesia, you get then the stent inside, and all your problems will be gone really easily. And so we have the rate of closing the fistula in 91%. This is really important. And only the 9% where it's not closed, then you have another problem, because that was then patients, they are treated after radiotherapy, where you have also a big problem where there's a tumor also inside it, their fistula not closing. But the rate of closing also after detection and putting it really early is 91%. Thanks. Some questions?
Thank you for your excellent speech.